when the heart is isolated like this, I always make my left hand as a diaphragm and then put the heart in this position, and then this is pretty much you are seeing the patient. Okay, so in doing so, what you here see is that here you have your right atrial appendage here, and then left atrial appendage here. So you can see that your pulmonary trunk here, and then aorta here. So pulmonary artery is right and anterior to aorta, left and anterior. In other words, aorta is right posterior to pulmonary trunk. If you see this relationship, this is called normally related great arteries. Okay? And then right ventricle on the right side and left ventricle on the left side. And the others are all normal. I'm opening the right ventricle. Okay. So this is the septal side, this is the parietal side. So this is the trabecular septum marginalis, body of trabecular septum marginalis, anterior limb of the trabecular septum marginalis. Posterior limb of trabecular septum marginalis is very, very attenuated. What is this muscle called? This one? So that is the medial papillary muscle of LNCC. So which means that because VSD is mostly to the left side, my left side of the papillary muscle of LNCC, this is called outlet VSD. However, so this is a tricuspid valve here, and then VSD comes all the way down to the tip of tricuspid valve, which means that this is a perimembranous VSD. And then conduction axis in this case, we're going to be coming in this way below the medial papillary muscle of LNCC. Okay? So that's why that if once it is diagnosed as a perimembranous VSD, surgeon will going to be careful in stitching in this part of the VSD. Okay. Anyway, then what you have here is that prominent here, the muscle ridge here. This is really the outlet septum. Why? Behind that you have aortic valve. In front of that you have your pulmonary valve. Therefore, the septum dividing subpulmonary and subaortic outflow tract is rightfully called outlet septum. It should be normally fit into this area where the VSD is. Therefore, this VSD is what? Leftward, forward, and superior deviation of the outlet septum, making a so-called anterior malalignment type of VSD here, and then the encroaching a little bit of subpulmonary outflow tract. In this case, that encroachment is not severe, but it's typically very similar to tetralogy of Fallot. So there are three different pathologic entities with a similar one. So leftward, anterior, and superior deviation of the outlet septum with severe subpulmonary stenosis, enough subpulmonary stenosis, we call tetralogy of Fallot. Okay. If your deviation is not associated with the subpulmonary outflow tract obstruction, and then that VSD is all the term Eisenmenger type of ventricular septal defect. Okay. So actually, this infundibular septal orientation is almost identical in this tetralogy of Fallot and Eisenmenger type of VSD. Okay. And then what is the double outlet right ventricle? A lot of question is that whether TOF is different from TORV. They are completely different things. What is that? TOF is describing this kind of malalignment of outlet septum with obliteration of subpulmonary outflow tract. That is the characteristics of the tetralogy of Fallot. In doing so, most of the time, what do we have? Overriding of the aorta. If the overriding of aorta is more than 50% in tetralogy of Fallot, you have TOF and DORV. Okay? In 1970s and 80s, they described DORV as that if there is more than 90% overriding. Okay? But that is a rather old concept. More precise concept will be tetralogy of Fallot. There is double outlet right ventricle if tetralogy of Fallot has more than 50% of overriding. So in that case, TOF and DORV coexist. Okay. So in this case, that overriding is approximately how much, Dr. Sir?
45%.
45%. Yeah. And then would you call this that tetralogy of Fallot?
Or Eisenmenger type is.
Yes, because subpulmonary stenosis is only mild. Okay. Okay. So from the left ventricle side, you can see aorto-mitral continuity, and then VSD is at the corner of that continuity, which is typical appearance of perimembranous VSD with outlet extension. Okay, here. Yeah. Okay. So this is done.
Yeah.
Okay. Can I pass? Yes, please. Okay. So this is the similar case. Again, that this is the cytosolitus livocardia, and the aorta is here. Okay, so this is not completely normally related because aorta is here, yes, and pulmonary artery is very small behind here. So would you call that a parallel, side by side great arteries?
It's difficult because they are very different in size. So.
Yes. So this is a pulmonary artery, and this is aorta. So it's similar to tetralogy of Fallot, but it's the hard to call this is normally related. Yeah. But it is not that very important. Anyway, opening the right ventricle. So here again, the orientation is this is the tricuspid valve, and this is the trabecular septum marginalis. So this is the anterior limb of trabecular septum marginalis. This is the posterior limb of trabecular septum marginalis. This is the medial papillary muscle of Lancis here, this one. So the VSD is almost identical to that seen in the last case. So this is a perimembranous VSD with outlet extension immediately below the aortic valve. And then what is removed here actually is between subaortic and subpulmonary outflow tract here. So this is actually outlet septum. This one is.
These all together can
together,
be,
yes. So what it is that the outlet septum is now completely exclusively right ventricular structure, separating subaortic and subpulmonary outflow tract, encroaching on severely subpulmonary outflow tract, and then that is why that the pulmonary valve is very, very tiny, and the main pulmonary artery is small too. So this is the another double outlet right ventricle with the subaortic perimembranous VSD, and then this is called, in other words, surgeons the terminology is TOF type of DORV. Okay. So, and from the right ventricle side, the left ventricle side again, you have mitral valve, and this VSD is the only outlet of the left ventricle, and then aortic valve and mitral valve are in fibrous continuity. So this is typical subaortic, the DORV with the subaortic VSD with the severe pulmonary stenosis. Okay. So this is a third last case, another the livocardia, and then right ventricle is open here, and it's a little bit destroyed, but however, what it is, so this is the trabecular septum marginalis. This is anterior limb of trabecular septum marginalis, and this is a posterior limb of trabecular septum marginalis, and this is a VSD cradled between anterior and posterior limb, which is very similar to that VSD. But however, outlet septum is not fused to this margin, but however, it is almost freestanding here, okay? And then in front of outlet septum, there is aortic outflow tract here, okay? So you have right ventricle giving rise to the pulmonary trunk and aorta with outlet septum intervening between them, and then subaortic outflow tract is significantly narrowed. However, the VSD is behind, this is behind, and the left side of outlet septum, and then immediately above that, you have pulmonary valve. So rightfully called subpulmonary VSD, okay? And then conceptually, this outlet septum should be here. Okay, and then what is the disease? Pulmonary valve should arise from the left ventricle, which is complete transposition. And then this outlet septum is deviating in this way. Therefore, there is severe subaortic outflow tract. In other words, the DORV with the subaortic VSD is commonly associated with subpulmonary stenosis, while that the DORV with the subpulmonary VSD, because outlet septum is deviating in this way, commonly associated with the subaortic stenosis, or at least a small aortic valve. And then because that in fetal life there is reduced blood flow through this pathway, there is common association of coarctation of aorta or interruption of the aortic arch. Okay? So if we go to the left ventricle side, surprisingly, the VSD is almost identical to the VSD we saw in the other case. Okay? So exactly the same location of the VSD, depending on the orientation of the outlet septum relative to the VSD, that can be subpulmonary and that can be subaortic. Okay. That's okay.
Excellent. Any questions?
Here in this case. Okay, so in this case, that's a good question. Tricuspid valve is here, and then there is the muscle between the tricuspid valve and VSD. So therefore, it is not perimembranous VSD. And then conduction axis, that if you identify the septal leaflet, the upper part of the tricuspid valve, behind there you have membranous septum. So therefore, conduction axis will be in this way. So a little bit off from the VSD margin. Very often that I find that subaortic VSD, mostly perimembranous, but however, subpulmonary VSD is more common in non-perimembranous.